everybody. My name is Shyllon, and the title of my project is the Dosimetric comparison of proton therapy and CyberKnife in stereotactic ablative radiotherapy treatment for liver cancer. And this was done under the supervision of Martin. Just as a way of introduction about liver cancer and metastases, liver cancer is the third most common cause of cancer-related deaths in 2018. And of primary liver cancer, hepatocellular carcinoma is the most common, accounting for 80% of cases. And the liver happens to be the most common site for the metastatic spread of cancer. This makes liver tumors a common occurrence. In terms of the liver is considered to have a parallel organ architecture and can be divided into 8 functionally independent segments according to the Kuhnert classification. This means the liver can recover from sufficiently small damage. What this means is that the best treatment is one that offers high localization, and the gold standard is surgical resection. However, only a small percentage of patients are eligible, hence the need for alternative forms, some of which are radiofrequency ablation, transaortal chemoembolization, and selective internal radiotherapy. But what we are interested in for this project is stereotactic ablative radiotherapy, SBRT, which is the precise delivery of very conformal and high radiation dose to the tumor and minimal dose to the surrounding normal tissue over a few fractions. And for SBRT to be successfully implemented, it needs adequate patient immobilization, a technique to manage respiratory motion, and image guidance. All these 3 things allows for the precise delivery to the target volume, which consists of a GTV, which is the gross demonstrable extent of the disease. And when there is not a technique to manage the respiratory motion, we add an ITV, which accounts for all the possible locations in the tumor, in the body that the tumor might occupy. And then we add a final setup margin to account for geometrical uncertainties. And so we have the CyberKnife system, which represents one of the ways to implement SBRT. And it combines a small 6 megavolt linear accelerator with image-guided robotic system to deliver photon-based SBRT. It has 6 degrees of freedom and a repositionable treatment couch. This allows a wide array of non-coplanar beam angles that can produce a highly conformal dose distribution. It also has image guidance using 2 orthogonally placed X-ray imagers, which when combined with a computer-controlled robotics allows for continuous tracking, detecting, and correction for tumor and patient movement throughout the treatment. Essentially, we're able to remove the ITV, reducing the dose to the normal tissue. So CyberKnife represents the cutting edge in terms of photon-based radiotherapy treatment. But when compared to protons, it's a slightly different story. This is because protons are perfect for SBRT. They have a favorable depth-dose relationship. Most of the energy for the protons is deposited at the end of its range, and they have no exit dose. This means a certain volume is kept free from receiving any radiation. Also, protons are more densely ionizing, meaning they are more biologically damaging. And the current clinical practice is to assign a 10% increase to the dose for protons per unit dose to reflect that increased biological effectiveness. And in order to cover the tumor volume with the dose, multiple Bragg peaks are stacked throughout the tumor volume to create a spread out Bragg peak. And in terms of the delivery, there's 2 ways to deliver proton therapy. The first is the old technology, which uses passively scattered proton beams along with beam shaping apertures and compensators to conform the beam to the shape of the tumor. This is being replaced by pencil beam scanning, which uses magnets to control the lateral, the X and Y direction of the beam, and controls the Z direction by changing the energy of the protons, and controls the dose deposition by controlling the intensity of the protons. So by controlling these three factors, we're able to achieve the eye conformity to the dose, to the tumor. So we have CyberKnife and we have Proton. However, there is no literature comparing the two for the treatment of liver cancer. The closest was by Peterson et al., which showed that the considerable sparing of normal liver tissue can be obtained using pencil beam scanning for solitary liver tumors. Another study showed that the radiation dose to the target was greater for proton plants, and the radiation dose to the uninvolved liver was not significantly different. But this study used passively scattered proton therapy. Another study using passively scattered proton therapy showed that proton SBRT reduced the average integral dose to the normal tissue by a factor of 2 compared with the proton plants. Therefore, the primary aim of the project is to perform possibly the first dosimetric comparison of CyberKnife SBRT and proton beam therapy for the treatment of hepatocellular carcinoma and liver metastases that will allow for a quantitative determination of which treatment modality is superior on a case-by-case level, and also allow us to identify factors that favors one modality over the other. And the results of the study are to serve as the framework for the generation of a clinical protocol. So the motivation for this study is to prepare for a proton facility that is expected to be built in South Australia in 2021. As a result, it is anticipated that the referral rates for proton therapy will increase. Therefore, in order to achieve highly efficient outcomes, we need to be able to identify patient groups that are most likely to benefit. The facility can only treat so many patients in a year, so we want to select patients for which proton therapy promises a superior outcome. Considering that CyberKnife has been used for the past 5 years, it has been established, and it serves as the benchmark for what is clinically acceptable. So we want to see cases and situations for which proton promises far superior outcomes. So the materials and methods can be simplified into 3 stages: plan generation, plan evaluation, and comparison. For the plan generation, for these data sets of 10 patients, 5 metastases and 5 hepatocellular carcinomas were used to generate proton and CyberKnife plans. Such as Gardner Hospital provided the CyberKnife plans using just the GTV, and Royal Adelaide Hospital provided the proton plans using both the ITV and the GTV. And the constraints for the plans for the for the tumor was 54 grays in 3 fractions for liver metastases and 45 gray in 3 fractions for hepatocellular carcinoma. And for the normal tissue, this was based on the UK consensus on normal tissue dose constraints for stereotactic radiotherapy. Once the plans were created, they were imported into 3D Slicer, which is a free open source platform for image analysis and scientific visualization. The addition of the radiotherapy extension allows plans from multiple sources to be imported into Slicer for visualization, analysis, comparison, and processing. So within the Slicer environment, the structures are visualized, the dose are visualized, and a CSV file containing the raw dose volume histogram data is generated. And in terms of the segmentation done in Slicer, this is an example for patient 1, which shows that the tumor spans segment 8 and 5. So using MATLAB, a script was created that is able to import the CSV file for every patient and compute a number of relevant quantitative metrics, and also to plot the dose volume histogram. The metrics computed are for the target, the mean, minimum, and maximum dose. For the chest wall, the maximum dose, and the minimum dose received by 30 cubic centimeter of the chest wall receiving the highest dose. For the lung, the volume receiving 20 gray or more. For the liver, the volume receiving 10 gray or more and the mean dose. For the skin, the maximum dose and the minimum dose received by 10 centimeter cube of the skin receiving the highest doses. And for the spinal cord, the maximum dose. The conformity index was also calculated according to this relation, which I'll speak more on later, and the radiobiological metrics, the tumor control probability, normal tissue control probability, and the generalized equivalent uniform dose was computed. All those parameters were computed using the dose volume histogram, which is a 2D graphical representation of the 3D dose distribution. It is essentially a plot of the volume receiving greater or equal to a particular, greater or equal to a dose versus that dose. So in terms of the formulations used, this is the formulations used used in MATLAB. There's too many of them. I've just listed them here for your convenience. So once all the parameters were generated, they were generated and exported into Excel for comparison. And these are the main and interesting results. Starting with the dose volume histogram, this is the results for patient 5. On the right, we have the CyberKnife, and on the left, we have the proton plans. The axes are on the x-axis, we have the dose, and on the y-axis, we have the volume. And this result is typical of what was generated for the 10 patients, with the exception of one, which I will mention shortly. What we notice, if we look at the liver as an example, is that for the CyberKnife plans, 100% of the volume receives some dose, and for the proton plans, 25% receives a dose, meaning that 75% of the organ is spared from receiving any radiation. This is a significant difference. But when we look at patient 8, we see that there's a little bit of a difference. It's a big difference. For the proton plans, we still have about 28% of the organ receiving a dose. And for the CyberKnife, it's about 40%, which is a significant drop or significant increase in organ sparing. And this was attributed to the small size of this particular tumor. This represented the smallest tumor volume at 2.8 centimeters cubed. For the quantitative assessment of the target, we can see that for all the plans, both the CyberKnife and the proton plans, they were all able to meet the prescription dose, but it is noticed that the CyberKnife plans were consistently hotter than the proton plans. And this was consistent for the generalized equivalent uniform dose and the tumor control probability. The reason for this could be due to a number of factors, such as the difference in the treatment planning software used and the algorithm, and also the choice of secondary collimator used for the CyberKnife plans, and the difference in the physics of protons and photons. When we look at the conformity index, if we look at the definition of the conformity index, and when I analyzed all the plans, it was noted that the volume of the target, TV, and the target volume receiving the prescription dose or more was equal, which reduces the conformity index to this relation, which is the ratio of the total volume receiving the prescription dose or more to the target volume receiving the prescription dose or more, which is simply the over-treatment ratio. So this tells us how much of the prescription dose is spilling into the normal tissue. And we can see that for all the plans, this is greater than 1, which indicates that both the CyberKnife and the proton plans have some level of over-treatment. However, is greater for the CyberKnife plans, which means that for the CyberKnife plans, there's a greater amount of dose spillage into the surrounding normal tissue, which is a direct consequence of the CyberKnife plans being hotter. When we look at the normal tissue assessment, we notice that the liver and the chest wall were the only two structures for which there was some level of violation of the dose constraints. And when we look at the numerical results, starting with the chest, we see that violations occurred for patients 10, 4, 5, and 7. And this was attributed to the proximity of the tumor to the chest wall. And the violations, as you could see, was for both the CyberKnife and the Proton plans, which means they are both affected by the same factors. Now for the liver, we see that the CyberKnife violated the optimal, not the mandatory, but the optimal limit for patients 1, 5, 7, and 9. Our patients 1, 5, 7, and 9 represented the largest tumor volumes, and patient 9 had 3 tumor volumes. And if we look at the plot of the mean dose to the liver versus the target volume, and the volume receiving 10 gray or more versus the target volume, we notice that for the CyberKnife plans, there is a general increase in the dose to the uninvolved liver as the tumor volume increases. But for the Proton plans, this appears to be relatively constant. For the CyberKnife, this can be understood in terms of the need to increase the number of beams, intensities, and incident angles to ensure full tumor coverage. But for the Proton plans, this is due to the physics of protons. Because of their finite range in matter, the biggest determining factor for the amount of liver dose is the amount of tissue they have to traverse before reaching the tumor. When we look at the generalized equivalent uniform dose, we see this trend play out. So this is the generalized equivalent uniform dose, which I should say is the dose that when uniformly given to a target results in the same biological endpoint as the actual dose distribution. We can see that patients 3, 4, 5, 9, and 10 are the greatest difference. So the plots here is the difference between the CyberKnife and the Proton plan for the GTV and the ITV. So we can see that patients 3 and 4 are the greatest difference. And this was attributed to the location of the tumor. If we look at the isodose distribution for those patients 3, 4, and 5, we can see that the proton beam is incident from directions that are close to the tumor. As the amount of normal tissue that has to be traversed is minimized. When we compare this to patient 8 and patient 6, which has quite a lot of tissue to be traversed, and we look at the results for the generalized equivalent dose, we notice that patient 6 and patient 8 are the smallest difference between the Proton and the CyberKnife plans. So that shows the effect of the amount of tissue that must be traversed by the Proton plans. This suggests that patients with tumors that are located in such locations could represent a subset that will benefit the most from proton beam therapy. And when we look at the NTCP relationship, it does not lend to a determination of superiority. It shows that for both the CyberKnife and the Proton plans, the NTCP is 0. But this is a mathematical result. We know that there is no advantage whatsoever to irradiating healthy tissue. So any opportunity to reduce or eliminate the dose should be taken. For the other organs, if we look at the chest wall and the skin, the result does not lend to a determination of superiority. And at this stage, it's probably worth mentioning that the yellow result is for the ITV, which indicates that there might be a significant difference. But we need to understand the ITV, by definition, has included a certain amount of normal tissue. So this result cannot really be used. When we do a quantitative, when we assess the difference between the ITV and for the Proton and the CyberKnife, we need more than quantitative assessment, which was beyond the scope of this project. But when we look at the lungs and the liver, we see that there's a clear difference between the proton and the CyberKnife plans. For the lungs, there's a number of cases where there is no dose received by the lung at all for the proton plans. And for the spinal cord, for all the patients, the dose to the spinal cord for the proton plans was 0. Even though the difference is not that much, with a maximum of 2 and 3, once again, we know that there is no advantage whatsoever to irradiating healthy tissue. So this result is quite significant. And for the NTCP, for the other tissues, we see similar results to that of the liver in that it does not lend to a determination of superiority. But like I said, this is just a mathematical result, and we take it with a grain of salt. So the conclusions are we've identified that the largest difference in organ sparing was for tumors that are located on the periphery of the liver and close to the chest wall, which indicates that patients with tumors at such locations could represent a subset that may benefit the most from proton beam therapy. One thing I did not, and we also saw that the CyberKnife plans in the beginning, when we look at the DVH, increased to comparable levels to the proton plans for small target volumes, and suggests that patients with relatively small tumors may represent a subset that should be given the least preference for proton beam therapy. Every patient will benefit from proton beam therapy according to these results. It's just who do we give the least preference to and who do we give the most preference to. So future work is to refine the code. I wrote quite an extensive code to automate the entire analysis steps. So I would like to refine it, maybe turn it into a GUI that will make life easier for clinicians. I can imagine there will be a lot of comparative analysis that will need to be done in the future for every patient to decide. So it would be good to have a tool that people can call on effectively when that time comes. So I have about 2 or 3 years to perfect it. To use a larger sample size to validate the conclusions drawn in this study, and to perform the study for other kinds of cancer, and to continue to the contributions to the development of Slicer. So during the course of the study, I had to do some modifications to the Slicer code, and I was able to contribute to the development. And even right now, they've continued where I left off, and are trying to add more complexity to the Slicer program. So those are the things that I would like to do. Thanks for listening, and these are the people I would like to acknowledge.